It is also a valuable tool in pediatric glaucoma patients, and one study showed that micropulse showed favorable results when compared to continuous wave with no major complications at 6 months follow-up. And in another study, there are also favorable results, and although 2/3 of the eyes required second treatment, again, no major complications were observed. Unfortunately, there is no consensus about the influence of prior glaucoma surgery on the success of micropulse. In one study showed that successful outcome was greater in eyes that had undergone prior traditional glaucoma surgeries like traps, tubes, or both. And another study showed a controversial result, saying that the results were similar. These different results were attributed to the different laser settings in the studies. So as micropulse is relatively new technique, laser settings need to be defined. As you can see here in the table, the laser settings range in a broad spectrum, and also the probe motion was applied in variable motions in different studies. IOP lowering effect seems to wane over time, although the early results are favorable at first months or second months. In the first year, the success rate is declining. One recent study with higher than usual settings for the management of elevated eye pressure, they did not show a drastic decline at first year, indicating a potential influence of the laser settings on the longevity of the procedure. Postoperative complications appear to be lower in micropulse versus continuous wave, and highest reported rate of prolonged hypotony was 3 times less in micropulse, and it appears to have a lower risk of visual acuity loss, anterior chamber inflammation, and cystoid macular edema. In endoscopic cyclophotocoagulation, the probe controls the ablation with direct visualization, and it is most commonly performed in conjunction with phacoemulsification surgery, which we call phaco-ECP. Studies comparing phaco-ECP to phaco alone, more than 2-fold reduction in IOP was observed in the phaco-ECP group, and it is also effective as a standalone procedure, and it is effective as a second surgery for refractory glaucoma that has failed a prior aqueous shunt implantation. It has similar efficacy in neovascular glaucoma patients as unexpected, and ECP may replace tube shunt in neovascular glaucoma patients. In pediatric glaucoma, the success rate was higher in glaucoma following cataract surgery in children, but in childhood glaucoma, the success rate was decreasing over the years. ECP has excellent flexibility, and it can be combined with VIX, which may add beneficial IOP decrease. And the ICE procedure is the combination of iStent injection, phacoemulsification, and ECP. And one study showed greater reduction in the ICE group compared to the iStent and phaco group after 12 months. ECP and phaco can also be combined with chaotic dual blade coniotomy, and mild to moderate glaucoma, the mean reduction IOP was significantly greater in the PAC group with no major complications. Hypotony or phthisis were fewer following ECP compared to both variants of CPC, and in neovascular glaucoma, the rate of hypotony was lower in the ECP group, and postoperative complications of phaco-ECP were similar to phaco alone. A decline in visual acuity was rarely seen with ECP when compared to other modalities. On the contrary, it increases the visual acuity of patients as it is most commonly performed with cataract surgery. And ultrasound cycloplasty uses ultrasound beams, and it does not depend on the pigmentation of the ciliary body epithelium, and it avoids collateral damage to the surrounding tissues. IOP reduction was greater in 8 seconds of treatment versus shorter durations, and the most common complications were superficial punctate keratitis, cataract development, and anterior chamber reaction. Visual acuity remained stable across all the studies mentioned in this review. With advances in technology, cyclodestruction has evolved from a procedure that used to be reserved for refractory glaucoma to a procedure that can be applied to any glaucoma patient. Owing to more targeted destruction of the ciliary body, it provides favorable IOP reduction with minimal complications. However, currently there are no large RCTs published to guide clinicians in the use of these modalities. As these techniques continue to evolve, it is important to establish standards for patient selection and device setting. Thank you.
And with this, we have the closing remarks from the Master of Surgery himself, Dr. Sharavi.
Thank you, Parol, and thank you for all the speakers for an excellent presentations and for keeping on time. I think this was a very interesting session that was very pragmatic, and every single one of us can go home having learned something. So I have a few comments on what I've heard. I think Parol gave us an excellent revision of the importance of contrast sensitivity in managing glaucoma, and for the glaucoma patient, how contrast sensitivity, loss of contrast sensitivity, affects significantly the quality of life of our patients. In Geneva, we have a standard care for our glaucoma patients via an educational program done by our nurses, where they go to the patients' houses and they look for many things to make their lives better. One of the things that they work on is contrast sensitivity in daily life. I think it's really important. She mentioned Sparks, which I think is a very good and free and easy to use tests that we can all offer to our patients. It's, as you know, it's computer internet based. It wouldn't take any specific equipment in your clinic to use it. Yasmin reminded us that 75% of obstruction lies in the angle, and angle surgery makes perfect sense. In a trabeculectomy, we go in and punch a piece of the eye and take it out, creating holes, while angle procedures are precisely targeting the site of obstruction. Whether ab externo or ab interno remains to be seen. But GAT, for example, which is a procedure that was notoriously difficult for many surgeons, now there are new devices that makes the operation easier, so makes it more accessible to surgeons that are not going to do 10 GATs per week. So the new devices are interesting, and I would recommend that you take a look at it. Noha spoke about the Asnoper clip and using a suprachoroidal clip in deep sclerectomy. We have published a paper on using another implant. It's a collagen implant in the suprachoroidal space. It was published in the March issue of last year of Journal of Glaucoma, and we could see clearly that putting something in the suprachoroidal space decreased the amount of pressure reduction. Incidentally, putting something in the suprachoroidal space was the idea of Gonzalo Munoz, who I know is in Dubai, unfortunately not with us here today, but just remembering that he was the person to introduce that originally. Umneya spoke about the iWatch, a Swiss invention. And the question with an iWatch is always very simple. You know, you're using a tap to reduce the aqueous going out and thus increasing or reducing pressure, and that makes perfect sense in the first couple of weeks after the operation. Now, the major amount of pressure resistance is going to happen distal to the plate in a tube or in a valve later on. So the actual, what you're doing initially might not be the overall determining factor. Having said so, there's another caveat. It's a conundrum. The caveat is, what if our better control of the pressure in the first 6 weeks would be translated into a better overall long-term reduction of intraocular pressure? This remains to be seen. We have very few RCTs comparing tubes to each other, especially in different scenarios. Dr. Kumar, who is the only male speaker of this session, did a brilliant job speaking about putting the Ahmed valve or other valves in the antechamber versus the sulcus. This is something that I've been personally very interested in for years, and we published on that. And it seems that we don't have a randomized controlled trial, a clean, decent one. His was retrospective, but of course very informative. It goes without saying that you might be in a better position to put the tube in the sulcus every time you have a pseudophakic case. That makes perfect sense to me, and this is what I'm practicing in Geneva. Now, he also mentioned something that is very clever, and this also pertains to corneal surgeons. If you develop a corneal edema, a corneal swelling after putting a tube, what should you do? Now, in all of those cases, you should attempt first to reposition the tube posteriorly if you can. Move it away. Not in every case, when you move it back, the cornea will regain function. This is actually doesn't happen always, but you still have to reposition, because if you are going to graft the cornea, you should not graft the cornea with the determining device that actually damaged it in the same place. So it makes perfect sense, as he said, to reposition the cornea. Dr. Zainab spoke about cyclodestruction, a very imprecise science, unfortunately. Yes, we have been doing a lot. We have been using a lot of new devices or new methods. She mentioned the high frequency. This is something that I worked on maybe 8 years ago, and I abandoned it actually because it didn't work well for me. It is, by definition, using cyclophotocoagulation is very much a shot in the dark. Why? Because you are using it in different circumstances for different patients, and because we're always using it more or less in very advanced cases. So an advanced case does not equal another advanced case. A refractory glaucomas are not born equal, so their condition is very different. Thus, the amount of cyclodestruction that you will do is also very artisanal. It is your impression, your gut feeling about what to do, because we don't have clear parameters up till now. The use of cyclodestruction in pediatric glaucoma cases is very controversial. I would only use cyclodestruction in pediatric cases after I have exhausted other things. So I would use it on top of a tube. I would not use it before a tube, but that's a personal opinion. I have seen papers where cyclodestruction, there's a famous paper from Mansoura University, I think, that uses cyclodestruction as a primary therapy for congenital glaucomas. This is a bit too excessive for my taste, but again, it is a matter of opinion, and again, congenital glaucoma cases or pediatric glaucoma cases are so varied and so very different